Hello, Assalamu alaikum, and welcome to all those who are joining this webinar that has been hosted by the British Islamic Medical Association and the National Burial Council. I'd like to just give a brief introduction on the webinar, which will cover different aspects. But the point of today's webinar is to be able to help support staff, to be able to educate the community on some of the changes that are going to be taking place from Monday, the 9th of September. So first of all, I'm going to give a brief overview of what the webinar will be covering. So the first thing will be the importance of timely burials, the death certificate system in England and Wales, and the change in legislation from the 9th of September. One of our other speakers will be covering the medical examiner's process and the statutory requirements, and how we will manage the new processes from a patient and family perspective, and then also from a community perspective. So first of all, I'd like to introduce our three key speakers. Our first speaker who will be speaking is Brother Omar from the National Burial Council, who leads in all issues related to death and burial in the Muslim community on a national, looking at this from a national perspective. And our second speaker that will be speaking is Dr. Salman Waqar, who will be speaking about the medical examiner's process. And our final speaker will be Sister Dr. Nadia, who is a consultant in palliative medicine. So first of all, can I hand over to Brother Omar, who will be speaking about the importance of timely burials. Thank you.
Good morning. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the webinar. Just want to, time is very short. We want to allow as much as possible for Q&As. In Islam, burials are extremely important in a timely manner. For us, you always heard the saying that we should bury somebody within 24 hours. Really speaking, you should bury somebody as quickly as possible. There is no mention of 24 hours, but we would like to make sure that it is buried at least within the same day if possible. That is why it's extremely important for us to bury somebody and as quickly as possible. What's the rationale behind it? Very simple. It's been narrated that when somebody dies, let us rush them to the grave. Why? Is it because we don't love our brothers and sisters? No, it's because of the fact that the hadith says that when somebody has been a good person in this world, let us rush them to the grave so that they can start to get all the good deeds and all the rewards for it. And similarly, if somebody has not been living in accordance with our required principles, then they will have to face whatever the consequences are. This is an extremely embedded principle within Islam, whereby we need to make sure that they need to ensure that they bury somebody as quickly as possible. Really, we cannot allow anybody to be delayed in terms of burial. Because remember, the fundamental principle within Islam is as well that most of the families will not start the grieving process until the person has been buried. This is of significant importance to all the stakeholders who are part of this process to ensure that the burial is done as quickly as possible. That is why when you go to a family, the first thing you probably say is give them the condolences. But the very next question will be asked is the fact that when is the burial taking place? This is why it is extremely important that this element of the quickness of burials and the haste of burials, just like the Jewish community, is embedded into the entire system. That is why one of the dignities we can give people is to make sure that they're buried as quickly as possible. One of the issues which we really found ourselves was during the pandemic, when because of the sheer numbers of death and also the reason of some of the complexities of the paperwork was being delayed. And you will know even 15, 20 years ago, when the system was really no provisions were being made for out of hours, no provision was being made for bank holidays and weekends. This has been a concerted effort over the years by both the Jewish community and the Muslim community to ensure that those communities which require a quick burial, that this has been taken into account. That is why we must make sure that we do this in a manner whereby the rights of the deceased is always taken as a priority. And for us, this is why it's important to bury somebody as quickly as possible. Coming on the death certification, what changes has been? The changes has not happened for over 50 years. What has necessitated these changes? Of course, the primary cause of it and what really started was the Shipman Inquiry. This really started as far back as 2007, when the first concept of death reformation was first mooted. That's where the medical examiner system was first thought about, was as far back as 2007. Then obviously there was the Mid-Staffordshire crisis, the Morecambe Bay investigation, the Gosport independent panel report, and also in this process, while the particular certification was going on, we also had the Lucy Letby cases as well. Not saying that had the medical examiner system been in place, all these particular aspects of it would have been taken into account, but there is a lot of room to say that some of these issues would have been tackled had the new system been in place at that time. In England and Wales, all of them, all the deaths were always had to be scrutinized by whoever it was in the past, but in the new system, this will need to be examined to make sure that every death is examined by either a medical examiner or a coroner's investigation. This was to give bereaved families the comfort and the assurance that the death of their loved one is being recorded accurately. If there is any issues which needed to be raised or there was concerns, that would be tackled. So this was the main reason to ensure that bereaved families were complaining that their particular deaths were not being investigated, or there was a cover-up between the medical practitioners, and to ensure that the true cause of death was not revealed to the families. That was the main necessity to change the system. And this is what the main reason was for what happened in the death certification system. A lot of them, if I can get to the next one, the important changes, I'll just go very briefly, the important, all deaths will now have to be reviewed by an independent person. And in this case, if it's a community or a hospital and an expected death, that will have to be reviewed by a medical examiner, or if it's an unexpected, and if it's a difficult case of either a homicide or that, will still need to be given by the coroner. But all deaths will have to be independently reviewed. This does mean that very much so that it is not going to be a question of a GP simply signing off a cause of death and completing an MCCD and sending to the registrar. That will no longer be the case. Neither will that be the case in a hospital as well. It will need to go through a medical examiner. So this is a fundamental change from the existing system, thereby an independent person will be the one who reviews the notes, the medical notes, and as well then offers, either concurs with the medical practitioner on the cause of death being offered, or they will have some discussion on that aspect of it as well. There was a requirement, and you know, all of us were very upset about if a GP has not seen somebody within the last 28 days, it would have to need to go to the coroner. This was causing so much problem, given the fact that some of the GPs we were not able to see due to them being very busy. So you would not even get an appointment to see a GP. So we also lobbied very hard on this to say that that is really not fair on the families. And fortunately, the medical examiner's team listened to us on that aspect of it. So the last 28 days is no longer necessary. So as long as the medical practitioner, whoever that may, has seen that patient in their lifetime, as long as they've seen them in their lifetime for the same illness, then are able to offer a cause of death for the person who's passed away. So that it is a major change, and this absolutely will help people who want quick burials. We hope that will go a long way in that aspect of it as well. The MCCD itself will change in terms of the fields. There are a couple of new fields which have been added on. One is ethnicity, one is pregnancy, and one is implants. What really affected us on this aspect of it, we did raise the issue that where you are recording ethnicity, you should also record faith as well at the same time. Regrettably, they said that they don't have enough time because even to get those changes, which are now on the MCCD, took them years to do so. But it is already on their list. So whenever any amendments are going to be made to the MCCD, once the new system has been bedded in, they are very conscious, both the Jewish community and ourselves have been very vocal in that you should also record faith. Why? Because then also for us, we as a Muslim community at the moment, we do not know the exact number of people from the Muslim community who have passed away because there is no record, there is no statistics. This is something which we have been arguing with the government for a long time, that we need to understand, not only for the purposes of planning, but also from terms of illnesses, as already been alluded before, that there is so much inequality in health for certain communities. And one of them is definitely the case of whereby the Muslim community, and specifically the BME community, whereby we have a higher number of stillbirth and neonatal death than any other communities. So we also need to understand and evaluate that data. Not only will it be good for the community itself, but for the whole of the NHS in terms of planning as well. The other thing which has changed is the 5-day registration period for once the MCCD has been issued by the medical examiner, the family has 5 days in which to register. Sadly, some of the families, because what used to happen before, once the green form has been issued by some of the registrar offices, in order to assist families, they will give you the burial order and will ask you to come and register the death the next day or in a couple of days' time. Some of them were really not following the rules. So therefore, they've made this mandatory that within 5 days of the MCCD being issued, the family must ensure that they register the death. This is something which we as a community should also be very mindful of, that when registrars and people are helping us out to ensure that they facilitate a quick burial, we should also reciprocate and ensure that the deaths are registered in a timely manner and within the statutory framework. These are the major changes. I think I've run out of my time, so I will give it over to the next person, whoever it is. Thank you for listening.
Thank you. That will be me. Assalamu alaikum. Hello, good morning. My name is Salman. I'm the president of BIMA, and I'm also an ME as well down in the southeast. So what I'm going to present to you is to try and distill what the role of the medical examiner is, what the processes are, and what the processes will become to the best of our understanding, knowing that this is something that usually has been discussed to date in day-long meetings, let alone in 10 minutes. So I will try and be as concise as possible, noting that I can't be as deep and as comprehensive as we would like to be. But there'll be plenty of time for questions afterwards for anyone having anything that they want to ask. So to recap, what is a medical examiner? We are people who are independent, and we're going to be scrutinizing the cause of death. We're generally senior practitioners, people who have been practicing for at least 5 years after they have been qualified, and we haven't been involved in the care of the patient. And that's a particularly key consideration, given the fact that there will be many clinicians, many doctors, excuse me, who do out of hours, who do locums, who work in the emergency department, for example, who may see many patients, and therefore they will be precluded from actually being involved in the care or the scrutiny of that patient. And that's going to be an important consideration later on, as we will see. And this is an opportunity for us to ask the family questions. We ask the doctors and the treating team questions as well, particularly where there is a lack of clarity as to what happened. It's not only the clinical element, it's also the other bits that surround it in terms of issues to do with safeguarding, issues to do with timely access to care, issues to do with missed diagnoses, delays to treatment, etc. And we are generally looking to try and be part of the quality improvement and patient safety element of healthcare, both in the community and in the acute sector. So what I'm going to do now is going to go through some slides. So hopefully I won't lose you as I go through it. So I'm just going to start from the top here in what things look like at the moment. So this is pre the new system. So this is as it is at the moment. We're talking about what happens in hours, and we're talking about what happens during an expected death. There is this concept of an attending practitioner or an attending doctor we put here for ease of wording. And an attending doctor, as has been mentioned before, there's a concept of being present in the final illness. So you'd have to be aware of what was going on in that person in their last illness. So if they're dying from cancer, you need to have been involved in that cancer. You couldn't have been involved, or you couldn't be treating them for their COPD, for example. And this has to have been a face-to-face review in the last 28 days of their life, or a video consultation, or after death of that person. And straight away, that limits the pool of people who could be involved in that care. If that attending doctor was not available, it would have to go to the coroner. If that didn't exist, excuse me, so if that person no one had seen the patient in the last 28 days, that would have had to go to coroner. But if the attending doctor was available, or unavailable rather, there was someone who had seen the patient within 28 days, but they were unavailable because they were on annual leave or because they're too busy, that again would have had to go to the coroner. The doctor then completes the MCCD, so that's filling out a cause of death. If the doctor is unable to offer a cause of death, and it's an expected death, that would also have had to go to the coroner. The doctor then sends that MCCD, that paperwork, to the registrar. The registrar is available, and they usually are in the hours. They will complete the registration, and the burial then proceeds and goes ahead. I've put here at the bottom, that the coroner has many routes by which they can get things out. So if they decide that there's no need for investigation, they can, at the moment, send things back into the system here. And as I said here, in most cases, if the attending doctor wasn't available, usually we would wait until the next working day. So say I, as a GP, was not in on Monday, you would wait until Tuesday when I was next in, practically speaking, to allow this to proceed. In the out of hours, the issue became around the availability of not only the attending doctor, but also the registrar. And if they were not available, if that alignment wasn't there, then that would have to then be delayed till the next working day. And the issue here was often, and still is actually often, around the availability of an attending doctor on the weekend in the community to actually write that MCCD. So what is happening, and we'll talk about what may happen, is that someone may have died on a Friday night, and they may be 98 years old, they're on an end-of-life pathway, they have been seen in the last 28 days by their doctor, but there's no one actually there to actually write the MCCD and to give that so that that can be sent to the registrar. And so, as it says at the bottom, there was a lot of goodwill in the system where out of hours people were having to be directly contacted, WhatsApp messages being sent out, trying to desperately find a doctor to fill that MCCD for this person who's passed away, to enable to facilitate that out of hours burial on a Saturday. But even if you had the MCCD, you then had the issue around the registrar being available. And then the registrar had to, of course, be available for that to then go ahead. So there's issues there, and this is all prior to the 9th of September. What will now happen is that the issue around the existence of an attending doctor should hopefully be something that is, in most cases, no longer an issue, because it's any doctor that has attended to the deceased in their lifetime. It does have an issue, as I said earlier, in terms of what happens then if you are also the ME and you happen to be working as an ME there. But those cases we hope will be small in number, but it's an important one to bear in mind, because if there isn't an existing attending doctor at all for some reason whatsoever, typically in the case of, say, a temporary resident, for instance, then that would then have to go to the coroner. An attending doctor is available. They will complete the MCCD. That MCCD will now be sent to the medical examiner. That medical examiner often will be sitting in an acute hospital trust, sometimes working remotely as well, and they will get that MCCD. So there is some paperwork involved here now in sending that to a new person. The medical examiner has to be available, and again, in hours, they will be, and they will then start to scrutinize the MCCD, and that can vary from a few minutes to an hour, possibly even longer, depending on how complicated it is. And it may not require a discussion with the doctor that's made the referral, because on paper, it's very straightforward. It's a nursing home death, there's an expected death, there's no issues around safeguarding, no concerns whatsoever. Or it may be slightly more involved, in which case the ME may wish to speak to the doctor that has made the MCCD, and that may also be due to errors. For example, there may be genuinely an error in the way that the MCD is written. It may be a lack of a need for clarification. It may be because the family has given something, and then that needs a little bit more exploration there as well. But assuming all that is okay, the medical examiner will then sign it, and then that will then get sent to the registrar. If the registrar is available, the registrar will then issue the paperwork, will allow the burial to go ahead. The new things that have come out as well here is that you'll see in this document that there are some in this diagram, there are some green arrows coming out from the coroner, and that is part of the reason for these reforms, is that the coroner is having to get involved in a lot of deaths and trying to minimize the amount of time that these things are sitting with the coroner. There is a way that the coroner can now issue, or instruct rather, a medical examiner to issue a death certificate in the absence of an attending doctor. So if an attending doctor is not available within a reasonable frame, as to again what that is yet to be decided, the coroner may instruct the medical examiner that you, medical examiner, issue an MCCD after reviewing the notes, and that allows the process to go ahead. But of course, that requires the coroner to be involved. So in that case, where someone hasn't got an attending doctor for whatever reason, or an attending doctor is not reasonably available within an appropriate time frame, then this potentially can be a way by which a death certificate can be issued. The other thing that they can do is that they can issue a form. It's the old 100A form, for those of you who know that process. They can also issue that. So they decide there's no need to investigate, and that may be because the doctors, for whatever reason, they decide there's no need to investigate, to do a formal inquest, post-mortem, etc. But the key difference here is that, as before, the coroner would send it back to the registrar, the coroner is now sending it further up the chain, back to the doctor, back to the attending practitioner who completed the MCCD, again having to go back and down the system through the ME for them to fill out the paperwork. And again, in this setting, we're talking about in the new system in the out of hours. What you can see, all we've done here is just highlight that the amount of people that have to now be involved in attending in this process, and the paperwork that's involved, has increased, and therefore the potential for delays to be introduced has also increased. So not only does an attending doctor have to be available on a Saturday morning, the medical examiner needs to be available on a Saturday morning, as does the registrar. And they all have to have dealt with this and done the due diligence and all the things that they need to do in a timely manner. And you can see how this can, it creates anxiety as to whether or not this will be done in a timely fashion. The other thing that was also, again, part of this is around that discussion that also needs to take place with the attending doctor. So as before, a doctor, out of their goodwill, may have been happy to have been woken up on a Saturday morning when they're not on duty to get a paper document and sign it for the death certificate. Not only there's a potential now that they also have to call the medical examiner to say that I want to have a discussion with you about this person that's passed away, and that would mean that doctor potentially needing to have access to the notes of the deceased so that they can discuss that case with the medical examiner. So again, potential for that goodwill to not necessarily carry forward within the new system. We're also in a process right now where there is collective action from general practice, and we know that there's a lot of concerns about doing further unfunded work in general practice. Very cognizant of that fact that these changes we rolled out whilst we're in the middle of that, certainly in the community. The availability of the attending doctor, again, we've spoken about that, and the goodwill element that's there. IT systems, we will know this is all stuff that's not specific to the Muslim community, but again, these are things that will disproportionately impact us, given all the things that we've already discussed. And also around the alignment of the medical examiner, the registrar in the out of hours, and indeed the coroner as well, making sure that's all aligned, and indeed even the cemetery, to make sure that all these services are there so that we can facilitate a timely burial for our patients. I'm going to hand over now to Nadia, who's just going to talk about the patient and family perspectives. And over to you, Nadia.
Jazakallah khair, thank you. Assalamu alaikum and hello to everyone. My name is Nadia. I'm a palliative care consultant in the Midlands, and I'm going to spend the next few minutes talking to you about how we, from a patient and community perspective, can try and improve the process, the way that it runs for us. And one of the ways which we feel quite strongly is important is the first link to this process, which is actually recognizing that a person may be approaching the end of their life. This is important because it then allows subsequent conversations to happen between both family, patient, but also with funeral directors and indeed the GP practice, where the attending practitioner will hopefully be identified for all that to run more smoothly, and so then the subsequent process can run through. So one of the things I wanted to talk to you about today was really about how we can prepare before the death happens, to try and ensure the process then runs more smoothly. And the key point here is thinking about really trying to embed advanced care planning better within our Muslim community. So just to introduce the concept of advanced care planning, essentially in practical terms, what it means is about thinking, taking a more thinking ahead approach to healthcare, particularly towards the end of life, in life-limiting illnesses, where you can expect that a death may well happen, rather than having more of a reactive or responding to a crisis approach when it's not actually necessary to be in that frame. This then allows healthcare teams to work with patients and their loved ones to be able to set and achieve common goals so that the right thing is done at the right time, and so the right outcomes are achieved. And this then allows for expected changes or problems towards the end of life to be discussed and planned for beforehand. And so, as I say, that increases the chances that important goals are achieved, and everyone involved has an understanding and a realistic expectation of what might happen, and therefore reduce down potential conflicts in perspective. It might also help to take the pressure off families to make certain crisis decisions as well. So in practicality, what might be the important goals? I find often for many people actually remaining at home towards the end of life is very important. And so there may be certain decision making that needs to be made around that. And this allows the family to be aware of upcoming expected death. And although there may be an element of uncertainty, even within sort of predictable life limiting illnesses, it allows the family to be prepared and to have the right conversations and to know what to expect, really. So these conversations around advanced care planning are obviously very sensitive, and so they might need to occur over a number of conversations or stages. Often they work best with healthcare practitioners or professionals where there's been continuity of care and a rapport has been built up. And by having these conversations, both the GP practice and attending practitioners will be aware of the importance of timely burial. We can't assume that every GP that we come into contact with or healthcare professional will know that. So again, this process of conversation is very important. It may also allow for video reviews to take place for patients who are identified as end of life, so that there's a greater pool of attending practitioners who will then be able to issue when the death actually happens. In addition to this, families are then able to also, if they're aware that the death may occur within the next few days or next few weeks even, they're able to liaise with their local Muslim Burial Council, funeral director services, and then get an understanding and a realistic expectation of what will happen post-death. So, is an out-of-hours burial, for example, even possible on a weekend? Are there other services such as the medical examiner and registrar available, which will then obviously influence the outcome of that? This also allows the GP attending practitioners to be aware and expect that a call may come in over a weekend or a bank holiday, and then allow them to issue the MCCD, or at least complete the MCCD and have the conversation with the ME. And hopefully this should be easier with the new changes that have come in. The MCCD will now not just be in paper format, it will be digital, which will also help with that process. Next slide, please. I think from a community perspective as well, if we are more aware of the potential issues, challenges, but also the nature of expected deaths and how they're managed in the UK, we can also advocate for the possibility of processes to put in place, which will allow death registrations to happen more easily. So an example of this is one of carrying out preemptive medical examiner reviews. So the idea behind this is that in expected deaths, we can actually make a referral to the ME with a proposed MCCD before the death actually takes place. This has been trialled in Birmingham and also in Manchester as well. There's a system in place. This proposed MCCD is then valid for 7 days, and it means that if the death occurs within those 7 days, then the attending practitioner can essentially go ahead and complete the MCCD without having to go through a loop where it's sort of checked by the medical examiner and then the attending practitioner fills it in. So it sort of reduces down the time there. If the death doesn't occur within that 7 days, and obviously there can be, as I say, a lot of uncertainty about death, even in life-limiting illnesses where it's fairly clear-cut, then the case will have to be resubmitted to the medical examiner. So again, there's some expectation management for the family there. But what we found in practice is that this system has worked well for expected deaths with a predictable trajectory. So, for example, with end-stage cancer patients, where there's very clear signs when people are in the last few days of life. It can be a bit more trickier if a person has end-stage dementia or something like heart failure, but again, the principle is there. In addition, if we're aware of the system issues that might be present in our own localities, we may then be able to, in our individual areas, lobby or campaign or have the right conversations with people in order to try and ensure that both the medical examiner and the registrar are available and aligned in the out-of-hours period, so that we can try and ensure burials can happen in that time frame. One of the challenges is our IT systems and patient shared care records, and that can be more difficult to influence as people within the community. But again, having that awareness there is important. Thank you. Next slide, please. So within BEMA and with the National Burial Council, we are trying to develop resources that will help from the family and community perspective, because sometimes it's actually just the lack of understanding or information. Often people may not have gone through the experience of having a loved one buried. It's a highly emotional, challenging time. And so actually having that information written down that people can then digest in their own time is helpful. So an example of the piece of work we're doing is a sort of a A4 sheet flow chart for relatives that they can read and understand before death what to think about doing, who to speak to, particularly the funeral director, who can help to guide them through the process, and also then after death, who the people are that are involved. Often the challenge that people have is there's so many different health professionals coming in and out of the house, different people to speak to, different point of contact. Can get very confusing, especially when you're going through that emotional journey of looking after your loved one as well. But there are other resources in development. If you have any particular feedback or ideas, please do share those as well. Next slide, please. And just finally, I just wanted to point out that there is a very helpful sort of summary guide of the changes that are happening from the 9th of September, which has been published by the Royal College of Pathologists, and it will be available on this slide deck as well. Thank you. I'll pass back to Sabia now.
Just before you do, Nadia, just if this last slide and then hand back to Savia, sorry, it's just around the next steps really, and then we'll open it up for question and answers as well. So really, I think it's clear that we need time to manifest itself so that we know what exactly will happen. A lot of these issues will require local solutions and local intelligence, clearly in an area where there's very few people that need timely burials, whether that's because of their Muslim or Jewish faith, or whether it's because of organ donation or other need for the urgent release of bodies. The needs will be different for each different area, and time will tell us what is and what isn't working. So we need to go into this with eyes open, knowing that this is a new system that's going to be live from the 9th of September. Just as much as our communities need to know that something new is coming forth, our funeral directors, of course, are aware that this is happening, but we need to get the message out there that if anyone passes away from the 9th of September, things are going to be a little bit different in the community than they have been so far. We talked about the need for resourcing. We talked about the fact that goodwill will not get us so far anymore, particularly in the community, in general practice, in the out of hours. We have some ideas as to what that could look like, but we also need to make sure that that is also matched with the availability and the alignment of not only the medical examiner's office in the out of hours, it's also the availability and the activities of the coroner and the registrar, and indeed the cemeteries. If you've got a green slip at 12 o'clock on a Sunday, but no cemetery is burying someone, that is also an issue as well. We talked about the need for advanced care planning and how that is an issue that we know in our communities that can be a challenge for various different reasons, but we need to keep working on it. And this is another reason why we have to do that. But I think a key additional element that we really need to get out to communities is that, as Brother Umar mentioned at the start, around the rationale for why the medical examiner system has come in, it is to allow the bereaved to have a say and a voice in the care of their loved ones. And if we are not having that voice, it is important that we do exercise that right to have that, and we don't inadvertently find that communities are not willing to share their concerns out of a fear that this will delay burial. And it is vitally important that that confidence is engendered both within the system and within the communities, so that we are able to have conversations that not only provide timely burial, but also contribute to high quality care, quality improvement, and patient safety as well. I put in here this point around non-funded, non-invasive autopsies because I think this is another reason why people are sometimes disinclined to begin a conversation that may end up in a coroner's referral, because they're worried that this will delay burial, but also they're worried that this will lead to an invasive post-mortem. I think if this was available, if this was talked about more openly, that there is a rapid, non-invasive post-mortem service available that will release the body quickly with dignity to your family, and that'll give answers and the reasons why we do autopsies. I think that would also help in the point that I raised before. And I think that is something that certainly the NBC and BMAV we've been talking about for a while. There's a huge inequity. There's a postcode lottery, in fact, as to whether or not that is offered to you and whether or not you have to pay for it. We already mentioned about the alignment, but I think the other thing here is also around the coroner. I think if the coroners are going to be involved, I think it's important that there is consistency in terms of what the coroners do and when they do it. So if you have got a patient that has had a neck or femur fracture and has had an operation done, if on paper that does need a coroner's referral, and that happens to be a death that occurs on Friday night, it shouldn't really need to wait until Monday. If it's a straightforward case that the coroner needs to be notified and they can allow the attending practitioner to issue the MCCD, there are things that like this that happen. And there's a concern that with this system, that also there's an opportunity for us to look at that and to try and address that, so that those queries that are made to coroners, where that isn't the routine practice for that to be looked at, there is an opportunity for us to discuss as to where that can be done in places where it is. And of course, there are places where that is done, and that is excellent. And that just leads on to the final point around sharing best practice and opportunities to do so, which I'm now going to hand over to Sabia to tell us a little bit more about.
Welcome back. I'd just like to say on we have our 9th annual conference, the National Burial Conference, on next week. And this will be, here we will have Dr. Alan Fletcher, and we will have Dr. James Aidley and other key speakers that we'll be speaking about to be able to elaborate on some of the things that we have discussed today. What I would like to do, if you would like to sign up to the conference, then please feel to screenshot the QR code and register for the conference. We have a few spaces left. So feel free to register for the conference, which will take place next Saturday on the 14th of September. What I would like to do now is open the floor for question and answers. I have got one question that I would like to answer myself, first of all, is I think it's from a chaplain, Usman Sheikh. What input can chaplaincy service offer to help families, medical professionals and Muslim burial providers? Somebody who works in the field myself, I'm a chaplain, and one of the important elements is for us to have the conversations early on. So if we're supporting families, to be able to have those conversations with the medical examiners, with the families, to talk a little bit about timely burials, and to be able to engage with the healthcare professionals. So offering training to staff around the issues around the need for timely burials for those from the Muslim community. We have a few questions in the chat, so can I just welcome back all of our speakers? What I would like to ask for is if we would like some feedback from the webinar, so feel free to screenshot the QR code and answer the questions on there. And now I'd like to open up the floor to our speakers, and if anybody has any questions, feel free to ask in the chat box. One of the questions that we have had is around, Dr. Hamad has asked, is this going to cause delays? Is the medical examiner's process going to cause further delays, or are we going to be expedite? Are things going to happen quickly? So, Salman, would you like to answer that? Or Mohammed, would you like to answer that question?
really speaking, I mean, it's very difficult to say. The system at the moment, which has been on an unstatutory stage, we really have not experienced major delays, but it really would depend on each trust, how best they are operating. So it's very difficult to say, but be prepared that there might be a slight delay in the initial stages while the system is bedded in. There are measures being put in by the National Medical Examiner to ensure that the faith requirements are taken very seriously, and they are taking steps in that, as we can see, that 7 days prior to that, you can even start making sure that things can start working quicker as well. So there are systems being put in place. I can't guarantee you 100% that there's not going to be any delays, but at the moment, the assurances we've got from the National Medical Examiner is that the delays will be very minimal, if at all. So let's evaluate it. I think once it becomes into a statutory phase, and the reason why I'm being a bit hesitant is the fact that the community deaths have really not been 100% certified at the moment by the medical examiner system. It will be done from the 9th of September. So that's going to be really, once we know after about a month or so, we will then be able to give you a better answer and a more determined answer. But be rest assured, for us and any community which require a quick burial, we will continue to press to make sure that there are systems in place which does not delay the burials of the loved one. Because at the end of the day, the government and everybody has been saying bereaved families should be in the center of it. And if there are, then they should make sure that certain provisions are made to cater for everybody's need. Chair, if I can just also add in terms of the one aspect which was asked about the MCCD being digital. There is an issue on that which was alluded to by Nadia. The IT systems have still not been worked out to say that we have a simple IT system which can be accessed by everybody concerned. They are working on it, and they were hoping that it would be ready by the 9th of September. It's not going to be, but the idea is to ensure that the MCCD will become digital, so it will become even more easier to do so. What's the time scale on the MCCD being digital? I can't give you at the moment, but we are in touch with the DHSC, who have been the Department of Health and Social Care, who have been tasked to do this particular job. So we will keep you advised on that aspect of it. Thank you.
Salman, I have a question for you. Will a call from the out-of-hours doctor qualify as an attending doctor, and will the MCCD be signed electronically?
So I think the electronic point, but Mohammed also just touched on. So it still has to be done on paper at the moment. It has to be the new forms. It can't be the old forms. So it has to be the new form, which has two sides to it. I mean, the new one, the old one also has two sides to it, but people don't know that. But the new one has got two elements to it, which talks about pregnancy and implants and so on. So that has to be paper. So any doctor who has attended to the deceased at any point in their lifetime is an attending practitioner. So, so I think there was another question in the chat. So if it's an unrelated illness, there's no concept of a final illness anymore. So that does open it up quite a bit for people to do that. But you have to be able to offer a cause of death. So if you, as a out-of-hours doctor, saw them for, you know, a cough or a cold, and they have advanced metastatic liver disease, are you confident that you can offer that cause of death? Have you got access to the notes? Have you got access to all that information to be able to do that? That's where that may become a slight issue. But there are instances, for example, in our area, I know that one of our out-of-hours doctors does and has taken it upon themselves to look after patients, and they referred to them to do a routine review of these patients on the expected end-of-life pathway, so that in the old system, there's someone that has physically seen them every 28 days, so that they are in a position to offer the MCCD should they pass away on a Friday night, Saturday night. And so that the MCCD can be offered. Excuse me, but they have had spent that time specifically on this issue in terms of understanding their needs and being able to be in a position where they can offer a cause of death. So as long as the out-of-hours doctor has gone in with that, then they could potentially be in a position, yes, to be someone that could be the attending practitioner. But again, you have to be the one that fills out that paperwork. So that goes to the medical examiner. You need to then be available for the medical examiner to then discuss it with you should there be any issues that arise from the scrutiny. And so you can see how there may potentially be bottlenecks that come out from that.
Thank you. Omar, we have a question. Mohammed, we have a question from Maria on the question of digital autopsy. Is any work being done currently to streamline what services are currently available, even if they are privately in each area, so families are able to access the information?
Yes, there are a lot of new digital autopsies coming on stream. It depends on which area you are. Our ask to the NHS, and also we were just talking to the Royal College of Pathologists as well, is the fact that there's a big shortage of pathologists at the moment in the whole country. And one of the suggestions we have put down to maybe as a solution, as that we should have a default position that any person which requires a post-mortem must go through a digital autopsy. There is a new facility which is open in London, whereby if the Coronial District of East London, any particular person requiring a post-mortem from a digital perspective, a CT scan or so, will be done absolutely free of charge to the family. This has already been done in a number of other areas like Kirklees as well, and some other areas as well. We have been asking the government to make sure that this can be replicated and this can be done nationwide. We want them to go back again to the pilot scheme, which was done in Leicester almost 10 years ago, whereby every post-mortem automatically as a default went into a scan. And it proved to be so successful that the NHS were unable to fund it nationwide. We are wanting them to do that again. There was a question as well, is to see whether anybody is asking the NHS and the government to increase funding. We have done so already, and we continue to ask the NHS as well as the government DHSC to make sure that this has been done. There is hopefully we will get. We are trying to meet up with the new government department at the Department of Health and Social Care, who are responsible for the budgeting and the funding of it, to see and make our case again into certain of these areas to give reassurances to the community, every community, that this new system will be robust, will be able to cater for the needs of the bereaved families. I'm not saying it's going to cater for 100%, but we will make sure that we'll continue to ensure that all the requirements of bereaved families are being adhered to or are being listened to by the government, and hopefully they will be able to fund it as well in due course.
Salman, one other question I wanted to ask that somebody's asked on the chat, I think there's a bit of confusion on the medical examiner's referral. So the question asked is the medical examiner's referral form no longer required? So I think they're thinking that if the MCCD has been sent, is a referral form not? But my understanding, it's different in each area. Do you want to just elaborate on that?
Yes, that's a lot of the issue. So a lot of people will want, the NHS has an ERS referral system, so a lot of people will want you to use that. So your admin team in hours will have to do that. In the out of hours, what we currently have where I work, for example, is that call will happen, and then the ERS referral will happen the next working day. So if someone dies on a Friday night, I'm gonna, there's a death that happens, then we will be notified on Saturday morning that this death has happened, and then we will be able to look in the notes, because we have the IT system where we use EMIS, where we are, all of our practices use EMIS, and I have access to the hospital notes as well, so I can do the scrutiny remotely. And if I need to, I've got a mobile number for the GP who has that notification of death has happened. So we can have that conversation. And then Monday morning, that GP's admin team will do the referral to the medical examiner service, so that all the paperwork is there then done, assuming that I'm happy for that death and that scrutiny is okay. So yes, there will need to be that paperwork there, which again just goes back to this issue around funding, this issue of around further work that is being put on GPs to do that further erodes goodwill, even in the in-hours. This is something that is going to add significant burden, especially those GPs that look after nursing homes, for example. I have come across colleagues who do nursing home ward rounds who are incredibly not happy with the fact that they have to now do tons of paperwork on a regular basis for these patients. But that's the system, and that's what we have to work with and try and identify where we can make improvements. But yes, a referral will be required.
We have Mohammed Mungero, who's also part of the National Burial Council on the panel. Just wanted to ask a question about elaborating more on the out of hours registration. Somebody's shared that in their experience, this has been one of the toughest things. Just want to share a little bit on the registration system and out of hours.
Yes, thanks. I think it's fair to say that most of the towns, most of the areas have their own systems. out of hours. So in Bolton, Manchester, in our areas, we have also deputy registrars, and we have a facility that's well catered for, probably from 10 till 3 o'clock. However, sometimes you now come to the point where the ME is only going to be available from 8:30 till 10:30, 11:30. So will they be available probably shorter hours? Will there be anything for them to do? So I think what they've tried to do is try and as much as possible to align the ME with the registrars out of our service. There are, however, towns and cities where there is no out of our service. Again, that's going to be a difficult one, which means it's no different to what you have now, because you couldn't register the death currently anyway. So yes, it is a big challenge, but I think the bigger challenge is going to be having the GP and the ME available at the time to make sure that they can be aligned and you can have the whole process come through together.
Thank you. Mohammed Iqbal, you've asked a question, what's the availability of MEs on weekends? And that is the key question. And each area will vary. We cannot give a staple answer for the whole of the UK. It's going to vary from some towns and cities might not have an on-call service on a weekend. Others might have an hour. Some might have 2, some might have 3. So it's different in each area, unfortunately. Nadia, did you want to share something about video calls?
Yes, I'd like to answer the question. There's a couple of questions around preemptive MCCD and whether that will be available in all regions. So at the moment, it's established in Birmingham, and we kindly have the lead ME on the call for Birmingham here. And she's responded that she is hoping that this will become available in all areas. So I think it's very important that we are asking our local ME offices and our local systems what are the plans for all of these different aspects. So availability out of hours for ME, for somebody who can sign the certificates, but also the idea of that preemptive ME referral. If we're able to ask those questions, then hopefully people will see that there's a demand and need there and try and resolve that.
Thank you. Asi asked the question, can I just confirm this is compulsory nationwide now from the 9th of September? We're in Rochdale and haven't had any recent updates as far as I am aware. And I'd just like to say, yes, that is compulsory. It's not something that can be avoided. It is a statutory requirement, and it's something that is going live on Monday. I've got most out-of-hours clinicians will not be comfortable to issue MCCD without knowing the patient. What will happen when? Then will the family wait till the next working day? Salman?
Yes, I mean, unless there's an attending practitioner available to offer a cause of death, then it'll have to wait until then. If the one is not available, then it will have to go to the coroner. And I suspect the coroner will probably not take the view that in the out of hours, if someone isn't available and you send a coroner's referral, that they will say, well, wait till Monday because an attending practitioner is available on Monday. This is where I think, we mentioned in the slides about where the in-hours GP services would be well placed to think about what could be done in terms of what local solutions could look like here, and these do need to be funded. Can't just continue to rely on goodwill for that to happen. As I mentioned in the pilot that we've had here in East Berkshire, has been that in the out of hours there has been someone that's done video calls, and again, you don't have to do them every 28 days now. It could be someone that knows the patient and has sort of got an understanding of what's going on and just feel like they are able to offer a cause of death for that patient once they have demise and they have access to records to be able to do that. The problem is that this is such a heavily contextualized issue that it has to have a local solution, that has to be locally resourced, it has to have people on board locally, and it has to have all the right safeguards in place so that we don't have people that unfortunately fall through, which do need to have that scrutiny applied to them. There are issues around safeguarding, there are issues to do with poor care, there are issues to do with whatever, and these are the things that this system is designed to pick up. So you have picked up a point which issues may arise, and that's why we have to be so important, as I mentioned, going into this eyes open, knowing where the issues are, and knowing that families are aware that this may be an issue, funeral directors are aware, as they are, that this is an issue, and that is communicated to patients. And that just circles back to the need for good anticipatory care planning. Because I know as a GP, all of us as GPs in the room, field directors, chaplains will know that unfortunately there are also cases where people just haven't quite understood that this person is imminently dying, and they haven't sort of made those matters, they haven't prepared themselves, they haven't thought about funerals, they haven't thought about these things. And if you can just try and be a little bit more active in that space as well, absolutely not saying that this is entirely their fault or anything like that, but I think there is a little bit more work that we can do around better death prognostication, around communication, and around preparation for this, so that we can facilitate a timely burial.
And the inevitable question, what happens when the IT system crashes? We've had issues, somebody's mentioned here, they've had no access for a few days. Is there a way to do a certificate if that does fail?
So, I asked this to our OMI service, and there will be business continuity plans in place, but many of these won't be stress tested. So there is an element, or we will have to wait and see. But the fact of the matter is, if you have no access to the medical records, you cannot carry out scrutiny. If you cannot carry out scrutiny, then this is a referral to the coroner. So if there is some prolonged sort of IT ransomware attack on the NHS, I'm sure there will be something that comes out that doesn't overwhelm the coroners and allows this to become an ongoing issue. But that's the issue. You cannot proceed unless scrutiny has taken place. This is now a statutory requirement. So if you cannot access the notes, you cannot do scrutiny, and therefore the process just stops there.
Okay, Mohammed Mungera, I have a question for you. Somebody's asked from a funeral service, Khalid Rahman. It's our job to collect the deceased from their home and place inside the masjid mortuary. Will this delay our position in respect to collecting the deceased? I can understand the potential delays in burial, but in respect of removing the deceased and bringing them to the masjid, is there going to be a delay in that?
I think the fair point to say that there may be delays in all the processes, because we need to make sure that all the due process have taken in place. However, having said that, currently discussions are taking place about what happens in death in the community. So, for instance, in the Manchester areas, we've been talking about when the police come out for a community death, or the ambulance service come out. Usually, they would be taken away to the mortuary. There's processes in place now where the NWS, with the ambulance service and the police, will do a triage and say, is this a natural death that they will be expected to get a cause of death from? Is it not violent? Is it a case? Is there trauma? Is it reportable to the coroner? They'll make that decision. Once it is, they'll probably make a decision to say it's fair to say to the family to ask your undertakers to move them to the mosque. So it may help that process. We may get them in the mosque quicker. However, it's going to be a process that the ambulance service and the police service are working on. So it's work in progress. Asked loads of questions yesterday about it, and we've got a briefing from our GMP, which is our model, but I'm sure it's the same. It's going to be across the country. So it may help, but in some places it may hinder, because if it's waiting for a green to be released in order to be able to release it, or an MCCD to be issued for the medical examiner to look at it, it may take time if there isn't one available out of hours.
And Mohammed Amr, I'd like to just ask you, what is it that the community can do to help in the system to make things seamless?
Yeah, first and foremost, I think I would just like to say that, the community has to be aware that this change is coming for, and have to take it on board, that there is no ifs and buts. We have to work with this new system. That's the first point. The second point I would like to say to the community is that a lot of you have become medical examiners. In the initial stages, we have to work on the goodwill, as we did on the GPs as well, under the current system. That is the only way we're going to be able to ensure that our communities are served, and they are on board to help out the community to make sure that they can do so. One of the problems we've always had is that the GPs were not able to provide out of our service because of the fact, various reasons are there. I'm not going to say. I did mention at one of the conferences when I was giving training to medical examiners that the biggest problem we have is GPs. And almost everybody erupted, so no, we are overworked. It's not a question of you GPs individually, but the system is such that we need to have ourselves, we need to be ready to ensure that we are able to contribute to this new system. And if we do that, that's the only way. So it's going to be a lot of goodwill as well in the initial stages, as Salman has already mentioned. In certain areas, there are already good practices occurring. So I think we will need to ensure that in the initial stages, some of us will, some of the GPs and everybody concerned should be able to try. And so instead of 1 hour, 2 hours, a question was asked, what about out of hours? It depends. The ideal scenario should be should be on call. That should be the ideal scenario. But you know, there are areas whereby there's going to be more deaths from a faith perspective, so they need to increase those hours. So it's going to be a bit of a trial and error in the initial stages. But please, you need to ensure as a community that you work very closely with your local medical examiners to ensure that your concerns and your requirements are actually very clearly demonstrated to them, and then let them also then, if they have got an issue, let them go to the national plan. But as I said, and as Sabir has said, it becomes a very much a local issue to try and influence it. But we will continue to influence it from a national. The reason is that initially the thought process was that the money was going to come from a national medical examiner itself. However, then they decided that the best way to do was to give the funding to each integrated ICBs, each integrated care boards, and then they would have to decide exactly how the money would have been done, but it's still ring fence for medical examiner system. So that's what we've been doing. So the community needs to be aware. We cannot afford to just panic. Let us try and understand the system. Let us see how best we can work for this particular system. At the end of the day, all those who are on call over here, we are looking after bereaved families, or we will be potentially looking after bereaved families. So it's our duty to ensure that we do not, we understand the system and we try and assure them as much as possible. So that's what would be my particular take on this one. And obviously, there is also, I'm sure Salman is aware of it, as Nadia is aware of it, they are trying to work on to expand the people who can be the attending practitioner. There's work going on to say maybe they could give a nurse who's been doing palliative care, she could become, so they're trying to do some work on that to try and make this process even more easier. So things will evolve, and we are thinking it will evolve for a better. They could do remote work during the pandemic. That is why our biggest evidence is the fact during the pandemic you could work remotely for everything. Surely, when everything is back to normal, you can do that as well.
Thank you very much, Salman. We have lots and lots of questions coming through thick and fast, but there's one particular question that I'd really like for you to answer. This is from Dr. Ross. Service for our Muslim community has been very variable in our area around timely burials. As a non-Muslim GP, who should I be contacting within the Muslim community to discuss and clarify options in our area and encourage better advanced care planning around time of death for our Muslim patients going forward? And that's Middlesbrough area.
I was going to ask if our funeral director, if Brother Mohammed could maybe come in on that, because I think that would be a very useful thing for them to share as to what good practice they've seen taking place with the funeral directors and mosques and so on. I don't know if either of you want to comment on that.
I leave it to Mohammed Mangera to answer it.
So in terms of what can be done, I guess if we can try and preempt if there are any expected deaths, we can work with the community to try and make sure that they're ready for that process and they understand that process. And I think more important is whether the GPs are going to make themselves available out of hours or to be able to deal with those cases. So I think it's a bit of both. It's making sure that the community are aware of what the process is, and the funeral directors also being able to have contact access to both yourselves as GPs and also the other stakeholders in terms of whether the registrars and that could probably help speed up the process.
Sorry, if I just can add on that one. If you are ever struggling to find out that, you know, who should you contact, it's always better if you can contact, we will have a regional lead from the NBC, National Burial Council, who would have a regional lead who will be able to help out. If you're ever struggling, just come to NBC, we will find you and we'll put you in the right direction. through our networks and through BIMA's network, we will be able to find a person who will be able to help you out to ensure that this process goes. Unfortunately, we have not come to the stage like the Jewish community where you can go to the Board of Deputies or some, but we will come to that, and NBC is in that role. So if anybody is struggling to try and find a local person in order to help or in order to manage expectations of families, please contact us and we will make sure we'll direct to the right person concerned.
Nadia, in your role, this is something that you deal with quite a lot. Is this something that you can also recommend? Sorry, you're muted, Nadia.
Apologies, I was answering some questions. I've missed that bit. What would you like me to answer?
Something a little bit about advanced care planning in the as a GP. How could they help? Who are the people that they need to contact in the community to be able to get things moving along? So what would your advice be for that?
Yeah, so if the patient is a palliative patient, not all palliative patients are known to hospice. Sometimes if there's a complex issue or there's a particular need, then the GP will have referred to the hospice system. And if that's the case, then more likely than not, there will be a specialist palliative care nurse involved who they're all excellently trained in advanced care planning, and they would be very, very good in terms of having that conversation with. If a hospice nurse isn't involved, then often general practices have a lead palliative care GP who is overseeing the service that's provided to palliative patients. So they would be a good contact, and then you can be signposted to the right people within your primary care system.
Thank you very much. I'd just like to say thank you to all our speakers for giving up your time to be able to be part of this webinar today, and for all those that have attended. We have lots and lots of questions that have come through, and we will try our best to be able to answer those questions and send out some answers. What I would really like is for you to be able to fill out the feedback form. So any ongoing work that we need to do as part of BIMA and the National Burial Council to help support communities and to help support healthcare professionals. The last point I'd really like to make is that this system here is to stay, and we need to do whatever we can to help support each and everyone in this system, and see what we can do to help facilitate things when it comes to families and healthcare professionals. And finally, I'd just like to say, if you'd still like to register for the conference, the details are on this final slide, and it's on the Saturday, the 14th of September. And if you have any questions for the National Medical Examiner lead, he will be there at the conference. Feel free to ask those questions to Dr. Alan Fletcher. Once again, thank you for your time. Any further questions, please do send your questions in on the email addresses that were provided for both the British Islamic Medical Association and for the National Burial Council. Once again, thank you for your time. Take care. Assalamu alaikum. Bye.